a mental disorder in year 10, and then they could be sent to a forensic hospital where the time of detention is not time limited, so they could be spending another 10 years afterwards in a forensic hospital. So that's the disadvantage, I guess, in terms of the time of detention. Consent to treatment is also an important issue to consider, and I would be interested to see how this is regulated in Egypt. In England, it is the case that for the first 3 months, treatment can be given, including medication mainly, and that does not require a specific consent for somebody who is detained. But after 3 months, the person either has to consent specifically to the treatment, or they need a second opinion doctor coming from outside the treatment team and outside the specific hospital to agree the treatment plan. And there are certain more severe interventions, like surgical interventions, that always require consent and cannot be performed without the person's consent. Important again is also how somebody gets out, and that's, I guess, to some extent similar in that there are also opportunities for tribunals that meet initially after 6 months and then every 12 months. And those tribunals consist of a judge, an independent psychiatrist, and a lay member. And the patient can apply for a tribunal once a year. And if they don't apply, they get one every 3 years anyway. And these tribunals can then make a decision to discharge the person, except for some cases who have additional restrictions where the Ministry of Justice also has to agree for the discharge. And those patients coming from prison, when they still have a prison sentence, they can also later be sent back to prison. But again, there is no involvement of the sentencing court. It is done by this tribunal, by the hospital authorities and the Ministry of Justice without a sentencing court. Just briefly to mention, again, you don't need to read all of these criteria, just to mention we have community treatment orders as well, which allow patients to be treated against their will in the community after they've been in a hospital, and that allows certain conditions to be placed upon the patient to ensure that they continue receiving their treatment, for example, that they attend the clinic and take their medication and so forth, and if they don't comply with those conditions, they can be recalled to hospital. And most forensic patients would have those treatment orders for community treatment after discharge. I already mentioned that insanity and diminished responsibility, while it is available, does not play a role in the decision regarding as to whether somebody is admitted to hospital or not. So I'm not going to say much about these two. I'm moving on instead to the development of forensic services in the UK, which started really in 1863, where the first high secure hospital, Broadmoor Hospital, was opened, called Criminal Lunatic Asylum at the time, and this was followed by 2 other high secure hospitals, Runton Hospital and Ashworth Hospital. Runton Hospital is where I worked and where also Samar and some other collaborators came to visit.
Very nice place.
Yes, and then in 1975 there was a committee put together that found that these 3 high secure hospitals do not provide enough opportunities for slow rehabilitation back into the community, because they only provide high secure services, and the step from those high secure services back into the community is quite a large one. So it was decided at that point that medium secure services would also be required as a step down, and low secure services were also later developed. So these are the 3 high secure hospitals. And they have between 200 and 350 beds. Only Runton Hospital caters for women and for those who are deaf and for those who have learning disability. So any woman in England who needs a high secure hospital bed will be at Runton Hospital. In addition to the high secure hospitals, as I said, we now have medium and low secure services as well. High secure services are very restrictive, and they should be reserved for patients who present a grave and immediate danger. They are quite expensive, £800 per day. You can do a lot of work with that. Medium secure services are for those with a presentation of serious danger. Again, these terms are subject to discussion between different services when decisions are made as to where somebody needs to go. There are about 50 medium secure services in the country. In total, they have about 4,000 beds. And then there are also many low secure services and community services. In theory, this tiered system should allow